morning, everyone. So we're going to transition over from one of the hottest topics to definitely the sweetest topic. And if we can get the slides going, that would be great. So my name is Nupur Narula. Thank you again for the honor to moderate the second session. We're going to be talking, the title of the session was Hidden Drivers of Cardiovascular Disease. It's absolutely an unhidden driver of cardiovascular disease. We'll talk about sugar in childhood and beyond. And I'd like to begin this topic by really talking about LDL. As neonates, we are born with a total cholesterol of about 70 and an LDL of about 25. And by the time we reach year one, we have an LDL of about 60. By the time we reach adulthood, we have an LDL of approximately 115 and a total cholesterol of about 200. And we are the only species on this planet that has a total cholesterol of about 200 when we reach adulthood. Every other wild mammal and even wild primate has a total cholesterol of about 100 or a little bit less than that. Now, if we look at LDL, or bad cholesterol, we are the only species that has an LDL greater than HDL, and all other species have an LDL of approximately 25 to 30. I think Dr. Smith alluded to the fact that dogs don't have coronary disease. So let's keep going a little bit further. What is the link between sugar? What is the link now between sugar and cholesterol levels? Well, certainly this was one proposed mechanism by Dr. Zubin Maslov, by Dr. Joseph Hill, the editor-in-chief of Circulation, by Dr. Thomas Lüscher, the past editor-in-chief of the European Heart Journal, by Dr. Jagat Narula, the president of WHF, and the prior executive editor of JACC. And this was really alluding to high sugar feeding in infant formulas. And we know that from infancy and beyond, we take in higher than the daily recommended added sugar limit every single day. So if you look at this mechanism, you have increased sugar resulting in increased insulin. This results to more production of PCSK9. PCSK9 binds to the LDL receptors on our liver cells. This causes degradation of LDL receptors, and you have more circulating LDL in the blood, one proposed mechanism. So in this topic today, or in this session, we're going to be talking about the impact of sugar on cardiovascular disease. We'll discuss the role of childhood sugar consumption, societal and environmental drivers of sugar consumption, public health strategies to reduce sugar consumption. We'll discuss the role of early intervention and prevention, and we'll review global efforts and policy recommendations. And on our elite panel today, we have Professor Adler. She's Professor of Diabetic Medicine and Health Policy at the Radcliffe Department of Medicine at the University of Oxford. We have Professor Bruce Neal, Executive Director of the George Institute for Global Health in Australia. Ms. Joanna Ralston, the CEO of World Obesity Federation, and Dr. Tadea Grachner, Research Scientist and Senior Economist at the Center for Economic and Social Research at USC. And we're going to start off the session with Dr. Grachner's outstanding pace-setter lecture and her thunderstorm paper that came out in Science in October 2024 that really demonstrated that exposure to increased sugar consumption before sugar rationing really resulted in a decreased risk of lifelong inflammatory diseases. So with that, I'll get Dr. Grachner on the stage.
Hello, everybody. Thank you for such a lovely introduction. Okay, so today what I'm going to talk to you about, as you alluded to, is basically what do we know about early life exposure to added sugar and how they affect long-term health. And then at the end of the presentation, we're going to touch a little bit about like what can we do about it and then move to the discussion afterwards. So let me start with some numbers. Also in yesterday's sessions, we talked about a high prevalence of overweight and obesity in adults. More than 2 billion of adults today are overweight or obese. But so are additional 340 children between ages 5 and 19. childhood obesity below age of 5 is about 6 to 7%, nearly double in the US, and it's rising. But it doesn't stop there. 1 in 6 children in the US are already diagnosed with elevated blood pressure. Prediabetes increased exponentially in the US from about 11% in the 90s to over 35% by 2020. Numbers are not much different for prevalence in cholesterol among this group. I think the prevalence in the US is about 7% in elevated cholesterol measures. And 1 in 5 children in this age group actually had an abnormal, at least one of the cholesterol measures in one of the representative study in the US. So these are not future risks. These are essentially early signs of chronic disease that are unfolding in middle school, not middle age. So one of the key risk factors that's been put forward in this discussion has been excessive intake of added sugar. I'm sure everybody here knows about what added sugar are, but let's just make it clear. Added sugar are actually added sugars that are added to beverages and foods during foods and beverage preparation. And that includes high corn fructose syrups, molasses, sucrose, yes, also maple syrup, yes, also honey. I hear that a lot, is honey included? Yes, it is. Another term that's used in this context is also free sugars, which are essentially added sugars with addition to sugars naturally present in juices and purees, which is quite relevant when we're thinking about infants and toddler foods in particular. So what are the sources of this, of added sugar, right? Everybody kind of is aware of added sugars being present in sugar and sweetened beverages, right? But we find sugar in so many other things. Another source of sugar that we're very familiar with are cakes, candies, confectionaries, but we don't really think about added sugar maybe when we're eating breakfast cereals, fruit yogurts, when we're eating sandwiches sometimes, bread, maybe drink coffee or tea that's sweetened. And there's so many other sources of added sugar that we're not thinking about, that are there, including ketchup and things like that you just eat without thinking about it. So what is too much? The current WHO recommendation is, I think I skipped one slide like this, right? Yeah. The current WHO recommendation set some limits, and the strict recommendation today is at about 10%, below 10% of total daily calorie intake. The conditional recommendation, meaning that, how much you should eat for health benefits, long-term health benefits, is below 5%. Now, we should probably be concerned, and we are, that's why this summit is about. More than 60% of adults in America exceed limits of added sugar. This one is for conditional limits. As you can see here, children and adults are consuming triple the recommended amounts per day, at about 20 teaspoons of added sugar a day, where recommendation is at about 6 to 7 teaspoons, depending on age and gender. But it's really concerning is that this kind of sugar-rich diet starts really early. The recent study in the US showed that on average, infants and toddlers are consuming about 4 teaspoons of added sugar a day. And by the time they reach 2 years of age, they're consuming 7 teaspoons a day, which is essentially a daily recommended amount maximum for adults. This is despite the recommendation that this particular age group should be consuming 0 added sugar at all. So how does this happen? How does this happen? Well, this happens through several pathways. It starts with maternal diet that can be high in sugar, either in utero or through breastfeeding. More than 70% of pregnant women and more than 50% of lactating women in America are exceeding the recommended amounts of added sugar. I have to say that this is not much different from general population. There are no specific guidelines into how much pregnant women should or lactating women should actually consume. It's not different from general population. The exposure then continues through, certain types of infant formula, and then especially after 6 months when solids are introduced through either sweetened, sugar beverages, juices, these toddler purees, toddler milks, cereal bars, and so on and so forth. So in the US right now, and it's not much different in other countries at this point, unfortunately, about 61% of infants and nearly all toddlers consume added sugar on a daily basis. So what do we know about this affecting long-term? We know a lot, but we also don't know enough. So there's still work to do. So what we do know in terms of causal evidence, a lot of it comes from animal studies, and they mostly show pretty robust evidence on adverse lasting effects on health. But these are usually studied in, using high doses of added sugar, and these are rats, like animal models, not humans. So in humans, we do have clinical trials, but these are largely smaller clinical trials. And what's really important to think about is that they have short follow-up. It's really expensive to follow people long-term, especially bigger samples. Now, what we do have from quasi-experimental studies, which are really robust as well, are long-term effects on metabolic health when people are exposed to suboptimal nutrition in utero. But the majority of these studies are kind of focused on extreme environments like famine and focused on caloric restriction rather than on specific nutrient alone. We do have a lot of work done that is correlational, based on observational studies, and longer ones especially that take, more years, they do find a pretty robust positive relationship between excess intake of sugar and poor metabolic health. But really rarely does early exposure to sugar connect to health beyond adolescence. And that's not that surprising because it's a very big challenge that this literature needs to overcome. And the challenge is that you need to find some sort of random exposure to sugar-rich diet early in life with outcomes that are measured decades later. So you have a lot of elements to think about. You need something that's random, you need early life, you need specific nutrient exposure, which is sugar in our case, and then you need data that's measured decades later. So it's a lot of boxes to tick, right, to check. So in this recent paper that you mentioned, we tried to overcome some of these challenges by exploiting this kind of unique environment, which was the end of sugar and sweets rationing in the UK in 1953. Now, I don't have time to go into detail what this rationing was about, but just really briefly, it was a part of a big food rationing after the World War II that started in the 40s, and one of the big parts of this rationing was rationing of sugar and sweets. Again, it wasn't banned, it was just rationed to certain proportions. And then it ended in September 1953, and what we're doing here is essentially we're exploiting this quasi-experimental variation in early life exposure to sugar-rich diet to say, well, children that were conceived, today's adults that were conceived just before and just after this event were essentially similar in everything except in their early exposure to sugar-rich environment. Okay, so their disease trajectories, in theory, should evolve in a similar way. So, just one second. Okay, so what was happening during the 50s? So we went to some historical records to see what were people actually eating during that time. What's sugar and sweets rationing actually binding? So as you can see here, the average intake of sugar and sweets during rationing was at about 6% of total energy intake. If you remember one of the slides in the beginning, that's basically within today's dietary guidelines. But what's really important is that after the rationing ended, you can see that consumption nearly doubled immediately after the rationing stopped. Okay, so and that's kind of like a key element of the study that needs to happen, otherwise we have nothing to study about. But another thing that's relevant, I don't know if you can see, is that changes in other food items didn't really happen, at least not in that extent. And we explored that in more detail across several food items, and more or less everything was kind of following either seasonality or, there was really no such a sharp change in any other nutrient or food groups. Importantly, when we look at the change in total calorie, the majority of the change in that total calorie came from sugar calories, more than 80% of that. So what happened 50, 60 years later? Okay, then we basically move forward and look at those adults that today are in their mid-age and see what happened to their type 2 diabetes and hypertension diagnosis. Well, in this graph, we basically estimated the relative risk between cohorts, right? The cohorts that were exposed to rationing early in life to cohorts that were never exposed. And what's really important in this graph is to see cohorts on this side. I don't know. I'm jet lagged, I don't know, this side, because I don't know which one's yours. On this side, what's really important, it is, right? Can you, is it here? It's here, right? This one, there we go. So this is really important part that, you know, you shouldn't ignore when you're looking at this study, is because we're comparing the risk of disease for these people that were never rationed. And this is our reference group. So basically, this is the first cohort that was born after the rationing. So what you can see here is their disease trajectory is pretty flat. So this is really important to rule out certain events or other confounding factors to say like, oh, these are just trend driving their results or some other events that were happening around that time. But when we're looking at the cohorts after, right, which is here, these are the people that were exposed to rationing early in life. The sugar restrictions, you can think of sugar rationing as sugar restrictions early in life. So what we found is that, if you were exposed only in utero to sugar restrictions, you experienced about 12% decrease in risk of type 2 diabetes onset and about 1.5 year delay in its onset by the time you were like about 55 to 65. If you're exposed longer, up to, you know, more than 1 year and up to 2 years, because we're basically looking at the window of about 1,000 days since conception, which is about, you know, in utero plus 2 years postnatally, we see about 35 degrees in decrease in risk reduction and about 4 years delay in diabetes onset. Now, so what we see here is that while in utero exposure mattered, benefits were largest postnatally. So in utero explains about 30% of the effect. And that is kind of linked with the period when solids are also introduced. We see very similar effects for hypertension. In particular, we see a reduction of, but the effects are slightly smaller. We see about 6% decrease in risk reduction for hypertension with about half a year delay in onset. And if the exposure is longer than 1 year and up to 2 years, the decrease in risk, relative risk, is about 20%, with a delay in onset of about 2 years. So what we did then, we said, well, you know, let's go into another data set and see whether we can replicate the results or find something else. So the results replicate for both of these outcomes, but we also looked at some other outcomes as well and used, you know, here what we're using is regression discontinuity approach. I'm not going to go into detail, but essentially the effect is estimated at the jump where the event happened. Okay, so we should be looking at this here. Okay. And these are people that were exposed to rationing, and these are people that were not exposed to rationing, because these are birth years, okay? So what we find here is that ration adults were less likely to be diagnosed with elevated cholesterol in their 60s, and they were also less likely to experience a cardiovascular event. It's not on a picture here, but essentially we defined it as what we have in the data, which is stroke, heart attack, or heart disease. We also had a measure of C-reactant protein at the time of the survey, and we defined you as, identified low-grade inflammation based on this marker, and we found a significant increase in the prevalence of people who were never rationed to be with low-grade inflammation. Now, we also saw some increased probability of arthritis if you were born after the rationing has ended. I know we didn't talk about that much, but I would like to highlight also a little bit of effects on economic outcomes, because I think they're an important part when we're talking about just welfare effects of, in relation to policies and improving health. So what we actually find is that exposure to early sugar rationing decreased the likelihood, exposure to sugar rationing or early life sugar restrictions increased the likelihood of you attending at least some college, of you ending up in a higher skilled occupation, and also accumulating above median wealth across lifespan, despite being equally likely to be employed. I'm not going to go through that. I'm probably out of time. There are several possible mechanisms behind these health effects, right? One of them that it's pretty often discussed is this metabolic programming in utero. The other one is reinforced sweet preference and reward sensitivity. There's a pretty common knowledge that humans we all like sweet, but how much we like it can be significantly modified in our early years based on what others have found. The third mechanism is also, what's the role of genetics? How does it interact with the environment, with early life environment in particular in this case? So we looked, just 1 second. We looked at the diet of these adults 50 years later using the similar approach, even though it's presented differently here. And we found that 50 years later, people that were exposed to sugar restriction early in life, even 6 decades later, consume less free sugar on average per day compared to people that were never rationed. And we're talking about 11 grams of free sugar a day. In addition, these people who are exposed to sugar restrictions also eat more intrinsic sugars that are present in fruits and vegetables. In particular, we see that the results is coming from eating more fruits. However, both of these people, on average, consume the same amount of total calorie intake a day, which implies almost that rationed adults seem to replace unhealthy for healthiest sugars. And if we translate these numbers, you can think of it as eating 2 more Oreo cookies a day, or 2 less if you're exposed to sugar rationing, eating 2 less Oreo cookies a day, or 1 more apple a day. And so that's why when we're thinking about these early life interventions, we need to think about something happening on and on and on, not just during that 2-year period, but we kick you off on some trajectory that might span a lifetime. I'm going to really quickly show you some of the preliminary results. Well, they're not that preliminary anymore, but they haven't published yet. Which is, we looked into also what can we say about genetic interaction with the early life environment. And we looked in particular in excess adiposity. I'm not going to spend time defining how it's defined, but it's using several measures of obesity. And we see that on average, we look at the increased, we see a decreased probability of people experiencing excess adiposity if they were exposed to sugar restrictions early in life. But when we look at, when we zoom into who these people were, after dividing them into 2 groups, one, based on the polygenic score data, we divide them into low genetic risk for obesity and people with a relatively higher genetic risk for obesity. We see that these people, these are at the low risk, genetic risk for obesity, seem to not benefit that much from these sugar restrictions. But when we look at a high risk population, they're the ones that benefit a lot. So when we're comparing the prevalence of excess adiposity between these 2 groups, low and high risk groups in adulthood, we see that sugar restrictions early in life decrease the gap between that prevalence by about 30%. So what are the opportunities to reduce added sugar early in life? Early in life is such a flexible period that I think it's a great window of opportunity for food policy or any kind of policy, as a matter of fact, to make a long-lasting change. So some of the possibilities are product reformulation, and if not that, at least clear labeling. Because when we look at labels, we can see a lot of what's in that food, but if you've ever been in a store with a toddler, raise your hand if you had time to read them carefully, okay? But when you zoom in, you see that, toddler milk, which is often marketed as something organic and great for growth, it has 30% of calories per serving size coming from added sugars. Yogurt melts, and again, this is not all of them, right? These are some that, I picked, but yogurt melts can get 40% of total calories per serving size coming from added sugar. So, there are several surveys that have been done in many countries that show that a lot of infant and toddler food are sourcing calories, more than 10 or 20% of calories are coming from added sugar. So what happened, for example, in Chile, they mandated food labeling with labels like high in sugar, high in calorie, high in sodium, and high in fats. And several studies looked into what happened after, which I find very interesting because you can see that people respond to policy. So first thing that happened is consumer actually shifted toward healthier items, moving away from labeled products that they previously thought that were healthy. So it's not that they moved, from candies to another candy. Candy's just sweet. As you can see here, nothing really happened in terms of reformulation in candy category. But they started shifting within from cereals that were high in sugar into cereals that maybe are a bit lower in sugar. What we also saw is that fewer products exceeded sugar limits after labeling law, and the average content of sugar in particular was about 12% lower in certain items that were studied, such as cereal. Another thing that I'm gonna stop, I promise, is price and marketing regulations, right, that we also talked about already yesterday. One of the things that I think it's almost impossible not to mention in this talk is soda taxes. And soda taxes have been, now implemented in over 100 places, either cities or countries, and the evidence is coming out nonstop. A lot of evidence right now is focused on sugar, like what happened to soda consumption. Some of the work has looked into what happens to overall diet, because we need to think about this as, a possibility for people to substitute towards something else that might be, even worse. But slowly and surely, the effects are also showing up in health. There's a very nice study that came out that I'm showing here, where they basically exploited quasi-experimental variation in soda taxes in US cities and found a significant improvement in maternal health as well as in newborn health only a few years after the soda tax was implemented. Similarly, we see some effects on adolescent health. In the US, we can see a decrease of BMI percentile adjusted for age and sex that fell, and the associations were strongest the younger the kids, and particularly strongest in children 2 to 5 years old. We did a similar study, because in the US, you have city-level tax. In Mexico, the tax was national, and what we studied was actually change in prevalence of overweight and obesity among adolescents as well, and we found a similar decline in adolescent girls. But what is important to note is that we find it only in areas where the tax passed through, meaning that the price changed at least 10%, which was the site of the tax, and not in other areas. So the policy needed to be aggressive enough to find an effect. And I think at the end, clearly, I think, even though all of these were kind of macro policies that weren't specifically targeting the early life, I do think that maybe we can, we also need to empower parents with improving parental literacy, with improving guidelines that we can lean on, and hopefully we can all work together and have even more promising results next time. Thank you so much.
Thank you so much. That was absolutely outstanding. So I think nothing highlights the role of primordial prevention more than this talk. So I'm going to switch to asking Dr. Adler the first question. You are an expert in diabetic medicine and health policy, so I'm going to ask you actually 2 questions. The first is going to be, can you tell us the relationship between excess sugar consumption, insulin resistance, and cardiovascular disease, both in children and adults? And secondly, can you tell us the role that we can play as healthcare professionals in further educating families, parents, really in the role that sugar consumption, especially the hidden risks that sugar consumption has, particularly in childhood?
Yes, happily. So we've known for a long time that countries with the highest sugar consumption also have the highest rates of obesity and diabetes. But of course, we didn't really know if the people eating that sugar were the ones that were getting obese and getting diabetes. So good observational studies have confirmed that the higher the sugar consumption, the higher the rates of obesity and diabetes. But that still didn't answer the question whether these people were fundamentally different in a way, which was increasing their risk rather than it being the sugar themselves. So many people assume that because diabetes is a condition where your blood sugars are high, it must be a result of eating sugars. And there has been not only the insulin-resistant hypothesis, but that you are actually wearing out your pancreas, since your pancreas has to make more insulin the more sugar you eat. What we do believe is that probably the mediator is obesity. So increasing sugar consumption makes people fat. And that in turn increases the risk of diabetes. One thing that is causal is that if you're obese as a child, you're very likely to be obese as an adult. And I understand that 80% of adolescents who are obese. So it's quite possible to become an obese adult without having been an obese child, but it certainly helps. Now, with respect to the advice we give people, it's not just obesity, of course. Dental caries are associated with eating sugar, and this has driven quite a lot of the guidance because there are good, possibly better trials in dentistry because it's difficult to show that decreasing sugar, as we've heard. And that's why your paper is so interesting, and it had a huge media impact. And I was asked specifically to comment on it. I mean, the opportunity for a natural experiment was one that I'm glad you took advantage of. What do we advise people who come to us? Well, we don't just tell them what not to eat, we encourage them what to eat. So all the important work on the Mediterranean diet and other well-rounded diets is important. The 10% we respect, it's been said by Paracelsus, the Swiss physician, that what differentiates a medicine and a poison is simply the dose. And so we know that there probably is some dose of sugar that's reasonable. I checked into my hotel right across the road here a couple nights ago, and I was a bit tired and hungry, and I stay there frequently, and I said, wait, where's the basket of candies that are usually here? Because I was looking forward to them, and they said, no, we don't do that anymore because it's not good for public health. So I was impressed with that. So yes, encourage people to eat less sugar. Don't leave it to the dietitian, but do it. But don't do it instead of the dietitian. Everybody should send the message. No one, to my knowledge, has proven that eating a lot of sugar has any benefits other than to the people that make the products with the high sugar.
And we'll definitely circle back to that with Dr. Grackner at the end. Thank you for that, Dr. Adler. I want to, ask Dr. Neal. Dr. Neal, we know that salt is not our friend, but certainly, as Dr. Chandrasekhar said, and as we've seen several times here already, sugar is certainly not our friend. And you have an impressive record of clinical interventions to deliver health gains. I want to touch upon something that Dr. Grackner mentioned in her talk, and that was the role of the beverage tax that you had demonstrated. But certainly, we see a steep rise in non-communicable diseases, including cardiovascular disease, in several countries, and several countries have progressed on their way to finding solutions. I hope you can talk to us a little bit about what South Africa has done and the South African government, especially as it relates to taxation in order to discourage sugar consumption. And then, kind of as a next step, if you can talk to us about whether these interventions have a proven benefit on both health, economic impact, and what kind of that social impact has really been overall.
That's a lot of questions. I may forget some, so do remind me. But
because then I have one more after that.
So I think it might be just worth reflecting at the beginning, just thinking about what is the sort of the food and beverage industry model. It's a bit of a generalization, but it's basically to take low-cost base product, add as much salt, fat, and sugar as you need to make it hyper-palatable, and then sell it in large portion sizes everywhere, all the time, on a high-volume, low-margin business model. And that's been desperately successful for big international food companies, but it's obviously been a complete disaster for public health. But it's a very powerful, very well-established business model, and it's really hard to break into that. And sugar tax or soda taxes, alongside taxes on alcohol and tobacco, have been some of the sort of, success stories in terms of trying to break into these big business models of the harmful commodity industries. South Africa is a nice example, one of those 100+ jurisdictions that now has a soda tax. The South African tax was actually, it was called the Health Promotion Levy. So obviously a levy is a better way to sell these things than a tax sometimes. And it was introduced, I think, in 2018. And it has a number of characteristics about it which are actually sort of good and thoughtful in terms of the way that that tax levy, was designed. So there was it was a targeted excise tax, so it's not part of a general sales tax, but it's targeted specifically at sodas. It also targets specifically sugar rather than just volume. So what it does is it says there's a base level of sugar content that is allowed, but for every gram per 100 milligram, per 100 mils above that, you have to pay a certain amount of additional tax. And that's good because it's really targeting the problem, which is the sugar, rather than just the soda, which arguably, if it didn't have as much sugar in, might not be so bad for you. And indeed, what we see with that sort of intervention is that you get a couple of things. So first of all, you get companies reducing the sugar concentration in the soda, which is great, and you also see less purchases of the soda as well. Now, you spoke a bit about it in your great lecture that introduced it. Thank you. We have pretty good evidence that if you implement a tax, you raise the price of the product and you reduce sales of the product, and you reduce sales not just of the volume but also of the quantity of sugar. You gave some nice examples of a few success stories, but you've been a little selective in picking some of those out. I mean, I know you would acknowledge that, and you said that. You know, when you look at the meta-analyses, you know, it does look promising, but we really lack that quality evidence about the downstream impacts on the health outcomes that we really care about, and we need to continue to try to gather that. You mentioned the economic piece. I mean, industry has fought long and hard against pretty much every case where jurisdictions have tried to bring in soda taxes, and they make a number of arguments that this is a regressive tax because it punishes those who are the poorest. There are others who actually make the argument it's actually progressive because, yes, it does cost them more, but they actually gain more from it, and even financially they're less sick, so they're able to do economically better out of it. There's also been the argument that this will put hundreds or tens of thousands of workers out of business, and there are some pretty reasonable analyses to suggest that that isn't the case, quite possibly because the big companies that make these products also make a bunch of other products which people switch to, or perhaps slightly more depressingly, perhaps the impacts of these taxes to date haven't been sufficient to actually drive the sorts of changes in manufacturing that would actually lead to job losses. So, in general, I think there's a lot to be said for these sorts of taxes. This is one of the few areas where we have seen success in implementation. We still need a whole bunch more data, but I think we would all be advocating that there was more of this and that they were implemented at a much higher level than they currently are.
And can I ask, you know, just to go beyond that a little bit further, how can we expand it really to other countries? And what is kind of the next step there?
Yeah, so I mean, I think expanding things to other countries, you know, is really helped by there being models for countries that have succeeded. That said, I mean, in the country that I live in at the moment, in Australia, we've argued for, you know, a soda tax for at least 10 years, probably nearly 20, and we have had no success. So you do have to be really targeted in terms of identifying what the opportunity is and when the opportunity comes along and what form of intervention is best going to be tailored towards that. And that is almost entirely political in my experience, that there is no, I may be wrong, others may disagree with me, but my sense is that you've got to find that political moment when something like this can happen. And that varies markedly from setting to setting.
Thank you so much. I want to go to Ms. Ralston next. You have really been the current or past CEO of really the best organizations across the Atlantic. American Cancer Society, WHF, most recently the World Obesity Foundation, and therefore you're really a champion in taking action against obesity, both in terms of prevention and in terms of management. And as we saw in Dr. Grackner's talk, non-communicable diseases, certainly cardiovascular disease, are on the rise, and one of the biggest drivers of this is obesity. We've also seen that increased sugar consumption, especially in high-risk individuals, is associated with increase in obesity there. That can, subsequently be extrapolated to an increase in coronary disease, an increase in stroke, an increase in peripheral artery disease, an increase in limb ischemia, all conditions that cause an increase in mortality, an increase in disability-adjusted life years. You had spoken at the UN, it's now a little over 2 weeks ago. The high-level meeting is now approaching, and my question for you is, how would you like to see the reduction in obesity incorporated in national health policies to limit the burden of cardiovascular disease? And are you able to talk a little bit about the lessons that we've learned from other countries that have actually successfully ventured to address the problem of obesity?
Thank you so much for that, and it's a pleasure to be here. And I want to thank, if you want to blame somebody for hiring me at World Heart Federation, it's Sid Smith in the audience there. It's very nice to see you, Dr. Smith. Thank you. This has been a great panel and fantastic presentation. I love these sort of. Let's go back to the 1940s. It reminds me of the bus driver study that was so formative as well. So, what I would say is, first of all, there's one of the reasons that I love working so much in obesity is it's so closely connected to cardiovascular disease, and they are essentially like the quintessential NCDs, like they are the NCD agenda in a way, and that is where my passion lies and why it's been such a privilege to do this work over the past X number of years. I think a couple of pieces that kind of came up that I thought would be helpful to consider is, one, obesity, if we look at the zero draft of the political declaration, obesity is addressed through taxation, through ambitions like 80% of member states would have coverage in sugar-sweetened beverage tax, et cetera. But it still does not sit in the health system as something that is measured in the early years, and that is going to continue to allow it to be under-addressed, and that's going to have a direct impact on cardiovascular disease and the other NCDs. I think obesity in primary care is, measuring BMI in a standardized way. Even though we know the limitations of BMI, it's a fantastic way and an affordable way, pretty simple way of capturing population burden of obesity, overweight and obesity, I should say. And it's not there. It's not been in primary care. It's not been understood that it belongs there, because there is countries that do measure it tend to have a better sense of what to do about it. I was really struck too by, so when we did in the atlas last year, I believe it was, we publish an atlas every year on World Obesity Day. We were looking at the elevated levels and the advanced, how rapidly, cholesterol and other cardiovascular indicators are rising and correlated with high BMI, and 88% by 2030. 88% of cases of childhood obesity will be in low and middle income countries, where we have even less understanding than we do in higher income countries. So it's this need for more data, more research to understand those drivers and enablers, while understanding that they are, many of those countries are going through what the tobacco industry kind of wrought on low and middle income countries once it became harder and harder and more expensive to sell tobacco in high income countries, was just to move operations over and make those high volume, low margin kind of sales. So that is a very real and big issue, and we need to have a better understanding of it, and that should be part of, interventions. Also understanding that still we are facing cultural preferences for higher weight among children in a number of places in the world, and we still don't understand that. We did a paper on sort of a global understanding of stigma, weight stigma, a couple of years back with 40 co-authors, which was, don't recommend, it's very complicated, but it was very, very inclusive. And it was interesting because when we sent it in 4 languages, but then we had only sent it in English to our Chinese colleagues. they said, you have to send this out in Mandarin. You need to reach a wider population here, of course. And again, China is a place that is anticipated to have 400 million people with obesity by 2035, 400 million, right? And when we got those results back and translated them, it was overwhelming how much cultural preference for, a larger child is a healthy child factored in, which you understand if you know a bit about Chinese history and, the history about, starvation and undernutrition. I think we just don't understand that well enough, both sort of biologically as well as culturally. And those are some factors that are playing into this as well, and the incredible, power that large companies have as employers. Sort of we will set up wonderful manufacturing and bottling facilities here in your country if you agree not to pursue taxation, if you agree not to support that. I have heard of very direct examples of that. Small island developing states that should not be significant markets to these companies, they're smart enough to know that they have, that they need to intervene and influence, both in those as well as middle, larger economies. So there's all these different factors coming together, but I think we really need to take obesity as seriously as we do. It's such a significant driver in cardiovascular disease and something that we could so effectively work together on. And we do, but it needs more explicit recognition that it is a significant problem unto itself and a driver of so many diseases, most significantly diabetes, cardiovascular, and several types of cancer.
Thank you so much. And Ms. Rolson, just if you could go on, if you could give us one country, for if you have an example of a country that has successfully tackled the problem.
Of childhood obesity or of?
Childhood obesity.
Weirdly enough, I'm going to say the UK is, for all its challenges, is doing a pretty good job. They're one of the countries I list. I also believe Mexico has done a lot of the right steps, and excitingly, you referenced that there's new data finally linking potentially a leveling off and lowering of obesity among adolescents. It's small, but it's the first data that says sugar-sweetened beverage, taxation can lead to a reduction in obesity. So that's Mexican data. So I would say those two. The UK is just a funny story. Is that one of the, there was lots of advocacy for. They'd been doing the right things more than other countries for a while, but they had a very interesting political window that opened when, strangely enough, Boris Johnson was prime minister and was hospitalized and almost died due to COVID, which was associated with his underlying obesity. So he had gone from being Mr. Stop Being the Nanny State to he had a conversion experience. And so finding those politicians with conversion experiences sometimes are the factor. All the research in the world won't prepare you for that, but if a window opens, grab it. And on World Obesity Day, the following, I think 2021, the UK committed £100 million to their national obesity strategy, and Johnson was very clear it was associated with his personal experience.
This kind of alludes to what you were speaking about as well, Dr. Neal.
Yeah.
So I want to end the session. I just want to go back to Dr. Grackner. Certainly your presentation showed a clear association between cardiovascular disease and increased sugar consumption. So what is the next step? And how can, mitigation of sugar consumption help reduction in healthcare costs, but how do you really balance this against a giant industry that lives and breathes sugar products? And let's end with that.
So I think these papers are kind of first papers coming out of a bigger research agenda to really understand how early life exposure to sugar. I want to focus, this early life. We know a lot about added sugar generally, but I think what we want to focus is to understand how early life exposure affects health. And here we touched on a few diseases. We wanted, we're wrapping up some work on actually related to outcomes related to cognitive functioning as well. Mm-hmm. We're going to dig deeper into cardiovascular diseases. But I think what we really want to understand better next are pathways and mechanisms behind these effects. Either it's, microbiome, either it's sweet preferences that form really early, and how do these people behave? What do we understand about sugar consumption? Including genetics, because I think that once we understand pathways, we can design better policies. And I would actually, we actually are working right now on trying to understand the addictive nature of sugar using a Mexican context, actually. And we do find evidence on sugar being an addictive agent in this story. And I think that's important to understand and add when we're interpreting policy effects, because if that's the case, then we shouldn't be that surprised that short-term effects are smaller, because it's a little sticky at the beginning, right? But over time, we can expect much bigger effects, because we estimated, for example, elasticity being like 1.5 times bigger. So I think patience is also, going to give us a better reality check. So I think, yeah, understanding the pathways. I mean, it's the same with, understanding genetics. And with that, what can we do in terms of recommending things at a more micro level? What can be done there? I don't know, how that's going to happen, but and unfold. But those are kind of the next immediate steps that we want to pursue and we're pursuing. In terms of healthcare cost, I think I would rather say this. What can we, look at this more from a societal perspective? What is the welfare improvement? What are the quality of life improvements, long-term value, when we're talking about, early life reduction in added sugar? And unfortunately, I don't have a number to give you yet, but there are clues, right? I mean, for example, just take diabetes. We spend over $400 billion in the US treating that disease, and individual costs are at about, $12,000, I think it's an estimate, per year, only tied to diabetes. And if we take, our results from our study, for example, and apply it to that, if early life sugar restriction delays the disease by about 4 years, that's a significant saving at the individual level alone, without even taking into consideration, hypertension, comorbidities that come with it, or even cognitive decline, right, down the line. The second thing that I think we can kind of get some clues on how effective this would be is other preventions that have been empirically evaluated that have been done early in life, right? So there's like really good evidence on cost effectiveness of different programs like nursing. I think it's called Nursing Family in the US, helping pregnant women and children early in life with a $6 return per dollar invested. There has been a lot of really good quasi-experimental evidence showing significant improvements in metabolic health and economic sufficiency with early life exposure to nutritional assistance, federally assisted programs and nutritional assistance like SNAP and food stamps. So I think we have a lot of, good evidence showing long-term effects on preschool interventions. So yes, they're not focused on sugar, but they show this cumulative effect of early life intervention and benefit that kind of just compounds over time. And the third is, we have several kind of papers that it's not based on empirical data per se, but it's microsimulations using the parameters that we do know, showing savings of soda taxes, for example, that are showing billions in savings in not so distant future. So I think that if we take the literature seriously, that early life does shape long-term health, then I think that given how much we're spending on managing these diseases, then investing in early life nutrition is not just good policy, it's probably common sense. And then what was the third question again? Oh,
your favorite,
no,
the industry.
I don't want to go into that. So I clearly have much less experience in policy than any of you here. But I don't know, naively, I would say it's not a zero-sum game. Hopefully, I think what needs to be done, and you probably all know that, I would say just aligning the incentives, right? I think just healthy choices need to be the easy choices. They need to be available, and I guess what needs to be stressed is nobody probably is trying to, ban sugar and collapse the industry whatsoever. It's just taking these added sugars from everyday foods like cereals, like yogurts, and put them back where they belong, into candies and birthday cakes. Nobody wants to take away that joy of like sometimes foods. I just think that parents, when they're buying feeding biscuits and infant like pouches, they just don't expect that they're packed with more sugar than a dessert. So I think that reformulation, clear labeling is these kind of things, product placement, proper marketing, I would say also really increased parental nutritional literacy is what is going to then drive demand for certain things, and then companies will probably have to follow. And there's some examples, that I'm more optimistic, in Chile, and I think in the UK as well, you had some reformulation of products after the sugar taxes, right? So you see, it's kind of interesting to see this bunching at the threshold. It's like they really go close, just so not to get the label being high in sugar or something. So I think, it's probably going to take a lot of time and energy from people that do such good work, but I hope that putting children's health in the center of all this and putting them in a health food system is going to win in the end.
Well, I love it. Thank you so much. We are definitely at time, but the conversation was certainly bittersweet, so thank you.